Hi, everybody. My apologies if there's any background noise. I am recording this as well. So we haven't done a new ECG in quite some time. So I was hoping we could just start off with maybe a slightly, not simple one, but maybe just whet our appetites for what may come in the next month or two. And just as we carry on learning. So for those of you who have been following for quite some time, you'll probably be able to pick it up quite easily and probably be able to find the answers quite quickly and things like that. But in any case, let's start. So we're going to have a look at this ECG today, which is a 57-year-old man, presents with chest pressure and diaphoresis. And, it's even if you've known anything about ECGs, you can already guess the answer, but we're going to go through it systematically, like how we always do. We're going to look at the axis, the rhythm, we'll analyze the rate, and then we look at each zone and see what we come up to. So, I mean, a 57-year-old man with chest pain and diaphoresis, your first thoughts would go towards ischemia, but you've got to think of differentials as well. So, pleural effusion would also fit in there. Pneumothorax may also fit in there. Pneumonia could also fit in there. Aortic dissection could also fit in there. So there's quite a few things that could fit into it. But I think after you've done this ECG, you might well find that it ends up being an ischemia. So my wife and daughter are fighting in the background over there. So my apologies if you can hear all of that. So let's get into it. So we're gonna let's start with the axis. So as we know, we would have normal, left, extreme right, and right. So let's have a look at lead one. So lead one is positive. So that means electricity is moving. And remember, this is lead one here. Let me just put that in. Sorry, I forgot about that. So that's lead one and lead AVF that we're going to look down. We're going to look at here at the bottom. All right. So let's start first and let's look at lead one. So lead one mainly positive. So we're going to say that we've either got left or a normal, and we can more or less discount an extreme right or right axis. And then if we look at AVF, now with this ST, with this S, okay, and then if we look at lead. And then if we look at lead AVF, let's just change the color over there. So lead AVF actually showing negative. So we've either got an extreme right or we've also got a left axis here. So I think with both of them being in this area, we can say that we've got a left-sided axis. So what does a left-sided axis tell us? A left-sided axis tells us that there's something happening on the right-hand side, or alternatively that there's damage that's taken place to the right-hand side. And that will kind of fit with what we find over here. So let's have a look at the rhythm. So let's see if we can find some P waves. So we can find some P waves over here. We can find them in lead V2. We can find them all over here. So the morphology of the P waves is quite normal. I'm not too worried about that. But especially when you come here, you notice that it's actually quite a big gap between your P wave and your QRS complex. So you're looking at about 6 blocks. And like we said, 2 to 4 is about the normal. So about 0.2 seconds. And here we're coming closer towards 0.3, almost 0.4 seconds. So we've got a first degree heart block. Now, it's quite regular. It doesn't really change. So it is a first degree heart block in this case. All right. And then we look at the QRS complexes themselves. So they're quite narrow. The QRSs follow every P and they're quite regular. So except for the first degree block, we basically got a regular rhythm, except for the first degree heart block. And then once we start looking at the rate, let's try and work that out. So normally you just find this at the top of your printer, but we work it out the old-fashioned way. 1, 2, 3, 4, 5. So 300 divided by 5 is 60. So we've got a rate of 60. Now let's look at each zone. So let's start with the inferior zone. In this case, we've got lead 2, 3, and AVF, which make up the inferior part of the heart. And we can see there's quite significant ST elevations that are going on over here. And what we can see is that the ST elevation in lead 3 is actually higher than lead 2. So if you remember from our previous discussions, that kind of tells us that this is a right-sided extension as well. So we've got inferior, and it's extending to the right as well. And if you watched our previous, then you know that once you see this, you should avoid TNT. Now, the reason for avoiding TNT is that the way TNT works, now you can give aspirin, you can give morphine, you can give everything else, clopidogrel, everything else on your protocol, but you just avoid TNT. The reason being TNT is a vasodilator. So we normally give that to dilate the coronary arteries, to allow more blood flow, to make the obstruction less obvious. But what happens is that you're also going to dilate your inferior vena cava. So that's going to lead to a decreased preload. And once you've got a decreased preload, then it eventually leads to decreased output and further decreases the preload. So you let your patient go into quite a severe hypotension after. So we know we've got inferior and right. The question is, if it's only there, are there any reciprocal changes? We've got to look for those things as well. So we've looked at the inferior zone. Let's look at the septum. So we look at V1 and V2, and we can see there are some reciprocal changes over there. It's could also show a posterior extension, but for now, we'll just say that we can see reciprocal changes. Now, when we come to the anterior part of the heart, V3 especially, we can see the ST depression. And when we come to V4, it starts to even out. And on V5 and V6, your lateral leads, we can actually see that we've got ST elevations again. And if we go to leads 1 and AVL, which are the high lateral leads, we actually see the ST depressions. So this will actually start telling us that this could be a lateral, or as I was saying, it could also be indicative of a posterior MI. But we know that we have an inferior, for sure, a right ventricular. So we would do a right-sided ECG, or the 15-lead ECG, where we do V4 on the right, V5 on the right, and V6 on the right, and we'd look for elevations on that side as well. And we probably get depressions here if it's a lateral MI as compared to a posterior MI. And to see whether it's a posterior MI, we do an ECG, 18-lead ECG, where we place everything at the back. Now, we've covered this before, so I'm not going to go through it again, but we can see we've got quite an extensive MI that's going on over there. All right. So this was the answer to it. So we've got a sinus rhythm with first-degree AV block, which we kind of had, a rate of 62, and acute inferolateral MI, so with possible right ventricular extension. So the only way that you'd confirm that is by doing a right-sided ECG or 15-lead ECG and posterior ECG to make sure. So we've got ST segment elevations present in the inferior and lateral leads with reciprocal ST depressions in 1 AVL and V1 to V3, where the magnitude of the ST segment elevation in lead 3 exceeds that in lead 2. The right ventricular infarction is very likely, as we had mentioned, and a more definitive diagnosis of right ventricular MI can be made by using right-sided precordial leads, all right, which they do later in the book that I'm using. But in this case, if it were me, I would also do a posterior 18-lead ECG, just to be able to see exactly how far this MI goes. So these patients, like I say, they do very, very badly when you give them TNT, but they do quite well and respond very well to PCI. They do respond to thrombolysis. The bad part is that this stands to correction as well. But generally, when the right side is involved, because it's the artery itself is of a slightly smaller diameter, they sometimes respond much better to PCI than they do to thrombolysis. Okay. And my apologies again for the background noise. My kids are actually busy having their snacks. And I think some of that noise may be bleeding through, even though I've got 2 doors closed. So my apologies. So these are just some signs of ischemia that you may see. Now, these are the cardinal symptoms that we all know: diaphoresis, sense of doom, restlessness. And this has to do with the catecholamine release. So that's adrenaline that's being released, cortisol that's being released. So this is why we actually give morphine. As much as it is a painkiller, it also helps to reduce these symptoms. Nausea and vomiting, definitely. Dyspnea, also very common. And retrosternal pain radiating to the left side of the body, which we also see quite often. And then non-specific warning signs. These are more common in female patients: dizziness, lightheadedness, fatigue, jaw, neck, and upper back pain, palpitations, epigastric discomfort or pressure. So there's a feeling amongst emergency physicians that once you have pain above the pelvis, an ECG is indicated regardless of what you think may be going on. And I kind of subscribe to that, because you've got so many syndromes that actually present, cardiac syndromes that present with such disparate presentations that what we would think of as cardinal symptoms don't actually apply. So especially for those of you who are going to work in private institutions or places where you could possibly be litigated against, even those in public institutions, my honest opinion is that if you have a patient with any pain, unless it's something obvious, I mean, like a stab wound or a gunshot, or, half the head is missing. I mean, even somebody presenting with headache or non-resolving dental pain, nasal aches, things like that, just do an ECG as part of your workup. It's not to say the ECG will definitely give you an answer, but at least if there is something cardiac going on, it can show you. And there's a lot of you who send me ECGs and you want to know if there's something, and you'll notice that I often tell you, listen, it's a possibility, but we can't say for sure. And the reason being, some of these changes can be non-specific, and it's only after years of reading ECGs that you can get to a point where you know something's definitely going on or not. And there's some wonderful resources that are becoming available online. For those of you who have a chance, go on to our Twitter page, and you'll see very often I retweet the ECG ECGs that come through on our Twitter feed. Although I think it's called X now, but I'm not sure. It hasn't changed on my on my home screen. But in any case, and follow those and look at how deep they go into some of these ECGs. And that's just a little joke to finish off, which I think is true. I don't know if anybody has this model of iPhone anymore, but. Okay, and hopefully we'll do another one soon. All right, keep well, and I hope you enjoyed it. Okay, bye.